Hello everyone, this is Dr. Turpin. I'm going to go over a few things related to thyroid and parathyroid imbalances just to make sure that you're clear on some of the diseases that can occur in those glands of the body. For the endocrine system, primarily the main things that we're covering is the pancreas, which we've already talked about in terms of diabetes. And now we're going to talk a little bit about the thyroid gland, which is located in the front of the throat, at the front of the trachea. And then the parathyroid glands, which are four little tiny small glands that sit out to the medial sides of the thyroid gland. And you can see that in the picture there. Again, the thyroid gland is a very vascular organ. The size of that gland is regulated by thyroid stimulating hormone that comes from the anterior pituitary gland. And while we're not going to focus a lot on pituitary gland problems per se, if for some reason the pituitary gland is not working well, and not putting out enough thyroid stimulating hormone, then the thyroid may not be producing as much thyroid hormone. And then there's some other things that kind of make that imbalance a little different. The thyroid gland, in response to that, does secrete or produce and secrete three different hormones, and that is thyroxine or T4, thiodothyronine, T3, and then calcitonin. And so the interesting thing is when there are circulating levels of thyroid hormone that are very low in the body for some reason, the hypothalamus causes the anterior pituitary to release thyroid stimulating hormone. So if you have high circulating thyroid hormone, then the anterior pituitary gland doesn't stimulate, sending out more thyroid stimulating hormone because it recognizes when there is too much thyroid hormone, and it will shut down and not do what it does to kind of get the whole process going. So if you think about it, you've got the pituitary gland recognizing the levels of thyroid hormone in the body and responding to send out TSH to the thyroid to stimulate it to make more thyroid hormone when necessary, and when not, it backs down and doesn't produce as much of the stimulating hormone. Another key point to remember is that iodine is also needed for thyroid hormone production. So if you don't have enough iodine in your diet, and in some third world countries that's pretty rare, you may see low thyroid levels in people from that. Other disorders that you see with the thyroid gland is, of course, a goiter, which is an enlargement of the thyroid gland. You may also see both benign and malignant nodules that form on the thyroid gland. You may have inflammation of the thyroid gland. And then you can have disorders of hyper and hypothyroidism, meaning hyper meaning production of too much circulating thyroid hormone in the bloodstream, or too little thyroid circulating hormone in the body. In terms of hyperthyroidism, there's a sustained increase in synthesis and release of thyroid hormone for some reason, thus causing a lot of this hormone to be circulating in the body. This disorder is seen predominantly with women that are aged 20 to 40 years. Graves' disease is the most common type of hyperthyroidism. And then you can also have what's called thyroid toxicosis. And this is when you have physiological effects that are being seen based on an excess of too much thyroid hormone, that being either T3 or T4. And with the thyroid toxicosis, and all that means is you're just toxic on thyroid hormone, basically. You have an increased metabolism, you have increased protein synthesis, and you also have an increased sympathetic nervous system response. So you can imagine that these people are high metabolism, they're skinny, they're just metabolizing stuff very readily, they get tremors and some of the kinds of symptoms that you would expect on somebody that is a very high speed type of individual in their behaviors. These are just some of the causes of hyperthyroidism. Graves' disease. You can also have a tumor on your pituitary gland, and because of that tumor growing, it may cause the pituitary to produce too much stimulating hormone that then in turn makes the thyroid gland produce too much thyroid hormone. You can also have a multinodular goiter that has grown on the thyroid, making it produce too much thyroid hormone. And you can also have a patient who maybe has been hypothyroid and is on thyroid medications and somehow forgot how many meds they'd taken or when they took it last, and they doubled up or tripled up and took too much, and now they have hyperthyroidism because of essentially an overdose of their medication. Diagnostics, of course, that you want to run, you're going to be looking for what is the T3 and T4 levels, and you expect those to be elevated. Your thyroid stimulating hormone could be either down or up, just depending on what is going on with the pituitary. So if your thyroid gland is out of whack and it is producing way too much thyroid hormone, then if the pituitary is normal, you'll see low thyroid stimulating hormone levels just because it realizes there's too much thyroid hormone coming from the thyroid. However, if there is a pituitary tumor, you'll see an increase in thyroid stimulating hormone as well as increase in thyroid hormones kind of downstream, and that's when you consider that the hyperthyroidism is secondary to the pituitary tumor. You may also see high radioactive iodine when you do some tests, and the thyroid scan is one of the key ones that you do, and it's called a radioactive iodine uptake exam. And the patient for this procedure takes an oral iodine pill, and then it's radioactive, and they monitor it through this scan to see how fast it is taken up by the system. That tells them whether or not the thyroid is overworking. They can also do what's called a fine needle aspirate of the thyroid itself to see what its function is. And these are just some explanations of kind of when you have hypothyroidism or hyperthyroidism and what you would expect in terms of your T4 as well as your TSH. And I would just try to become familiar with that, and if you're unclear about why one would be up or down in these situations, please feel free to email me for some more clarification on that. So go-getter Gertrude, everything about her is running wild except her periods, and that is a symptom of someone who has hyperthyroidism. They typically are very thin, again, have all those symptoms that we discussed, and then these are the huge clinical manifestation list that you will see. Increased heart rate, increased blood pressure, increased basal metabolic rate. They may have heart palpitations, they may have an increased appetite, but at the same time they have increased weight loss, they have increased peristalsis, meaning that their bowels are moving very rapidly. They may show symptoms of diaphoresis and exophthalmia, which I'm going to show you some pictures of, and insomnia, of course, because of being so high strung. These are just the symptoms by percentage of patients. 100% of patients usually have tachycardia. 90% will have the anxiety, tremor, and weight loss. 90% will have what's called a heat intolerance, and they will get febrile very easily. They may have skeletal muscle weakness, and they may develop fatigue. But most patients tend to have the majority of clinical symptoms. Just be aware. Graves' disease is caused by an autoimmune disease that causes antibodies to attach to the TSH receptor on the thyroid, and it stimulates release of T3, T4, or both. So it is an autoimmune disease that kind of creates hyperthyroidism in a person. So basically they have an overstimulated thyroid gland. And this accounts for 80% of the hyperthyroidism cases that you will see. So the majority are due to Graves' disease. Women are 5 times more likely to have this than men. If you have an insufficient iodine supply, that is associated with this as well. Infections, or where you've had inflammation related to the thyroid gland. If you have a stressful life event and or are a cigarette smoker, those are also risk factors for Graves' disease. Graves' disease also causes exophthalmia, which is a condition where inflammation of byproducts from this huge inflammation that takes place in your body occurs, and those will deposit themselves with pressure behind and around the eyes, and so you get these huge bulging eyeballs that are very easily noted on assessment. This may be in an active versus an inactive phase. The person may actually keep this kind of huge protruding, bulging eyes for 3 months up to a couple of years, and sometimes even with treatment things don't respond, and they may end up with that as an ongoing condition forevermore. Sometimes steroid therapy can be useful, and sometimes a type of cosmetic surgery can be done, but oftentimes some of those are not real effective as well. Patients with Graves' disease will often have a goiter, and you can see on this patient how swollen this lady's neck is as well. That shows you what the goiter looks like. Main outcomes and things you're trying to accomplish with care is you want to put these patients on anti-thyroid medications. They may need to be on radioactive iodine therapy. They may need to have a partial or total thyroidectomy to take away some of the excess growth of the benign tumor, if that's what's causing it. They will have high calorie dietary needs, high protein needs, and high carbohydrate needs, but they do need to avoid high fiber and seasoned foods. This is just an example of some of the treatment in more detail. Tapazole inhibits thyroid hormone production, and it's taken daily. PTU will also inhibit thyroid hormone production. It's usually given 3 times a day, and often will be given for up to 12 weeks to become therapeutic. You have to teach the patient about signs and symptoms of hypothyroidism so that they don't then rebound and go too low on this medication. The radioactive iodine therapy cannot be used in pregnant women.